last decade, since we saw the results of using CDK4/6 inhibitors in those patients with metastatic breast cancer, where it has an overall survival advantage, the question then comes, in patients with intermediate and high risk of recurrence, does adjuvant CDK4/6 inhibition further improve prognostic outcome? So let's go through a case. This is a 30-year-old lady. She's from the Philippines. She's married. She's got 2 children. Mother had breast cancer at the age of 45. She presented with a left breast lump and a palpable axillary lymph node. Biopsy confirms that this is an invasive ductal carcinoma, ER+/HR+, HER2 negative, grade 3 disease with a Ki-67 of 35%. Lymph node is positive for disease. PET-CT does not show any metastatic disease. She undergoes breast conservation surgery, axillary lymph node dissection. She's got a 6-centimeter primary with 3 out of 10 lymph nodes that are positive. So this is a PT3N1M0 disease. So some of the questions that we ask ourselves in the clinic, in the MDTs, is should she be tested for BRCA? Of course she should, because she's young at the age of diagnosis and she's got a positive family history. So she goes on to be tested and she has no BRCA1 or BRCA2 mutation. Now, she does fit the criteria to send her tissue for genomic profiling, so the question comes, should we actually do it? In our perspective, when we discussed her case in the MDT, she's young at the age of diagnosis, it's a grade 3 disease, Ki-67 is 35%, 3 lymph nodes positive, and as you've heard the results of the responder trial that told us that in premenopausal women, irrespective of the Oncotype DX score, these women actually benefit from chemotherapy, so the decision was to give her adjuvant chemotherapy with an ACT-type protocol. Post that, should she receive ovarian function suppression? Soft in text tells us, yes, we should. So then the question comes, what is her now risk of recurrence post doing all that, and should she deserve or should she receive adjuvant CDK4/6? So I did that. I plugged her information into the Predict NHS score, and what you essentially see is with giving appropriate chemotherapy, surgery, radiation, and adjuvant, third-generation adjuvant endocrine therapy with ovarian function suppression and an AI, the probability that she'll be alive at 5 years is 76%. So the question then comes, can we do better in terms of risk reduction? So we know that in patients that when we're trying to overcome recurrence in these patients, we need to identify where these recurrences are coming from and why. We do realize that some patients actually recur very, very early, and these are the patients who have primary endocrine resistance. Can we overcome that with CDK4/6 inhibition? We also know that these patients, based on certain characteristics, they have higher risk of recurrence. If they've got more than 4 positive lymph nodes, the risk of recurrence is 3 times that of node-negative patients. Grade 3 versus grade 1, 2, more than 3.9 times. More than a 5-centimeter tumor versus a less than 5-centimeter tumor, more than 1.9 times the risk. And of course, those patients with a high Ki-67 versus a low Ki-67, the risk is more than 1.8 times. So can we further stratify the risk in the clinic when that patient is presenting to you and sitting across from you at your consultation? So this is the way I look at my patients who are sitting in the clinic with an ER-positive, HER2-negative disease. They either have an N2, N3 disease or N1 with high risk with those patients with more than a 5-centimeter tumor or grade 3 disease, or N1 low risk or node-negative high risk, again, those patients, high Ki-67, big tumors, grade 3 disease, or genomically high risk. And then, of course, you have those node-negative low-risk tumors. We tend to bucket those patients who are N2, N3 with or N1 high risk because we do have data, real-world data, that tells you that the high-risk group of patients, those node-positive high-risk group, have more than a 3-fold risk of recurrence compared to those patients who are considered to be low risk, either node-positive or node-negative. And what you see from the right-hand side of the Kaplan-Meier curves, you can see that amongst those patients who have node-positive high risk, all of them have actually high risk of recurrence, whether they're N1, N2, or N3. Now, what about the difference between N1 high risk and N1 low risk? Well, the difference between N1 high risk and N1 low risk is there's almost a 15% absolute difference in terms of increasing the risk of a recurrence that translates into a 2.2-fold higher risk of recurrence. Now, what if we try to compare those N1 high risk to N1 low risk and node negative high risk and node negative low risk? So what essentially you see is that the highest risk of patients are the N1 high risk, then followed by the N1 low risk, followed by the node negative low risk, and then of course the lowest risk of recurrence are in those patients with node negative low risk. Now this was a very interesting real-world data set that Hope Rugo actually presented at ESMO Breast last year, and I want you to focus only on that first graph, which essentially tells us that those patients, node positive, high risk, have the same risk of recurrence as early stage triple negative breast cancer, telling us in the clinic we should not ignore these patients. Their risk of recurrence very, very similar to the early stage triple negative breast cancer. So going back to this particular patient, she's young, 30 years old. She's got all the high-risk features, grade 3, Ki 67, 35%, 6 centimeter tumor with 3 lymph nodes that are positive. So she fits in that N2, N3, or N1 high-risk group of patients where we have 2 important clinical trials that essentially asks the question, can CDK4/6 inhibition improve prognostic outcome in patients with high-risk hormone receptor positive, HER2 negative early stage breast cancer? We've got the Monarch E trial, which was the first CDK4/6 inhibitor trial to actually look at this question. Patients with ultra high risk disease, where they finished their surgery, their chemotherapy, their radiation therapy, were randomized to get 2 years of adjuvant abemaciclib with standard of care endocrine therapy versus getting endocrine therapy alone. The primary objective of the study was invasive disease-free survival. This was the definition of high risk in the Monarch E trial, more than or equal to 4 positive lymph nodes that constituted 60% of the cohort, 1 to 3 positive lymph nodes with a high risk feature which constituted approximately 40% of the cohort. Last year at ESMO, we saw the updated results, 7-year follow-up of the Monarch E trial, where you can see a 7-year absolute difference of 6.5%, favoring the group of patients who are getting adjuvant 2 years of abemaciclib with endocrine therapy that translated into a 26.6% reduction in the risk of developing recurrence of disease. But the question that we asked ourselves is, this continued separation of the Kaplan-Meier curves that we're seeing, will we see it with additional follow-up? And that will be something, as more and more time passes, that we will be able to answer in terms of the question. In terms of the secondary endpoint, overall survival, last year at ESMO, we finally saw positive results in terms of overall survival. You can see a 7-year absolute benefit of 1.8%, favoring the group of patients who are getting 2 years of adjuvant abemaciclib, and you can see the deaths from metastatic disease actually coming in, with higher incidence in those patients who did not receive adjuvant abemaciclib. Now, one of the questions that increasingly comes up is, should it have taken this long to show an overall survival benefit in such a high-risk group of patients? And my answer to that question is yes, because these are ER-positive, HER2-negative group of patients. They're getting optimal adjuvant endocrine therapy, so we do see later recurrences. Furthermore, when these patients recur, they're getting very good metastatic therapy in the form of a CDK4/6 inhibitor. So this was an appropriate time where we would start to see that separation in the Kaplan-Meier curves. Can we show that CDK4/6 inhibitors actually improves prognostic outcome not only in that high-risk group of patients, but in the intermediate risk group of patients as well? And so that's where Natalie came into effect. Very similarly designed to the Monarch E trial, but it took a broader cohort of patients. Some of the key differences, they had about 5,000 patients that were actually enrolled. Early stage, hormone receptor positive, HER2 negative early stage breast cancer. The dose of ribociclib that was used was not your traditional 600, but 400 milligrams per day. And instead of giving 2 years of adjuvant CDK4/6 like the Monarch E here they gave 3 years of adjuvant CDK4/6 with ribociclib. Like I said, it used a broader cohort of patients. So yes, that ultra-high risk group of patients were enrolled, but they also enrolled node-negative patients who had high-risk features, such as either having grade 3 disease or grade 2 plus additional high-risk features such as genomically high risk or high Ki 67. And of course, those patients with T3, T4 node-negative patients were also enrolled in this study. You can see that the node-negative cohort of patients constituted approximately 30% of the patients that were enrolled. The N2, N3, which was the overlapping population with Monarch E, approximately 20% of these patients were in that overlapping population. Again, an updated presentation of the analysis last year at ESMO, 5-year follow-up, where you can see that all patients had completed their 2 years of adjuvant at least 2 years of adjuvant ribociclib. You can see 5-year absolute difference of 4.5%, similar to what we're seeing with the Monarch E trial. But what's even more important, again, will we continue to see the separation, the Kaplan-Meier curves? Again, we need further follow-up to be able to answer that question. Very important, over time you can see stability of those hazard ratios, telling us the effect is the same over time. And I thought this was a very important piece of data when we're actually looking at our patients in the clinic. And of course, most of the events that we're seeing were actually distant events that you're actually trying to prevent. Because I always tell my patient in the clinic, I don't care if your tumor comes back in your breast, we can still cure you. But if the disease comes back at a site distant from the breast, that's where we run into trouble, because that's where lifespan is in fact shortened. What about those node-negative patients? Remember, 30% of those patients had node-negative disease. And you can see that there's a benefit both in the node-negative cohort and the node-positive cohort. If anything, the node-negative cohort of patients appear to be doing better with adjuvant ribociclib. 5.7% absolute difference at 5 years, and this was statistically significant, telling us in those high-risk group of node-negative patients, we should not ignore them. They do recur, and they do need adjuvant CDK4/6 inhibition. Stage 2 and stage 3 disease, again, both cohorts of patients are benefiting with the use of adjuvant ribociclib. When you're looking at the overall survival, again, this was presented at ESMO last year. Not statistically significant, but you're starting to see a separation in the Kaplan-Meier curves. And at 5 years, again, this is a trend. It's not statistically significant, but you do see a 1.6% absolute difference favoring the group of patients who are getting adjuvant ribociclib. So again, those questions that we asked, should she receive ovarian function suppression? Yes, softened text tells us that she should be getting it. Should she receive adjuvant CDK4/6? Remember, 3 lymph nodes positive, 6-centimeter tumor, Ki 67-35%. So the decision was to give her an AI, GnRH analog, and a CDK4/6 inhibitor. But which CDK4/6 inhibitor am I going to give this patient? Because she's in that overlapping group of patients. And I think it distills down to the toxicities that we will see, and sort of individualizing it to that patient that's sitting opposite you in the clinic. Monarch E, which adjuvant abemaciclib, the main side effects included diarrhea, fatigue, arthralgia, and honestly, in my part of the world, and I don't know if you have that in your part of the world, but in the Middle East, people like to have a little bit of diarrhea because they're all unanimously constipated, so they actually like taking abemaciclib. The NATALEE, yes, more neutropenia, and you have to be aware of QTc prolongation, grade 3 QTc prolongation anywhere between 0.5% to 2%. Now, for me as an oncologist, I've forgotten how to read ECGs. So my cardiologist is so happy with me because when I give ribociclib, I give them appointments, and so they get to bill these patients and read those ECGs. So they're actually very happy. So it's not too bad in terms of monitoring your patients, which is literally in the first 2 months. Now, what about that intermediate group of patients, which is only in the NATALEE trial, those patients with N1 low risk, those patients with node-negative disease? How do we define these patients? So let's put another case. A 45-year-old lady, this lady is actually a physician. She presents with a left breast lump, palpable axillary lymph node, IDC, ER/PR positive, HER2 negative, grade 1 with a Ki 67 of 10%, lymph node positive disease. She has her surgery, 3-centimeter primary with 1 lymph node that's positive. So she's purely NATALEE in terms of entry criteria. So should she receive ovarian function suppression? Yes. Should she receive adjuvant CDK4/6 inhibitor? Well, she's got 1 lymph node that's positive, 3-centimeter tumor, Ki 67, 10%, grade 1 disease. She actually fits the Natalie criteria. And when you go down into the stage of the disease and looking at the absolute benefit, you can see hazard ratio 0.8, telling us this woman is going to benefit from adjuvant CDK4/6 inhibitor. So the decision was to give adjuvant ribociclib, but this lady required dose reduction. She's actually driving me crazy in the clinic, because every time she comes, I see a white blood cell count, an absolute neutrophil count of 0.5, and she's perfectly fine. But she requires a lot of dose delays and dose reductions. But we're now at 200, and the question is, does it impact efficacy? And the simple answer, it doesn't. We've seen this from Natalie, and you can see there's absolutely no difference when you go down on the dose, and we've seen something similar in the monarch-E trial as well. So if you need to go down on your dose, it is very safe to do so. Now, what about that node-negative cohort of patients? Question is, do all node-negative high-risk require adjuvant CDK4/6? So I'm going to go into the real-world data set that comes from the Flatiron database that shows us the difference between node-negative low-risk, node-negative high-risk, and node-positive patients. And what you essentially see is your N2, N3 disease have the highest risk of recurrence. And we know that. We've seen it in the monarch-E trial, and Natalie, they benefit, and they benefit a lot from getting adjuvant CDK4/6. But when you look at the node-negative high-risk and the N1 disease patients, they do exactly the same in terms of risk of recurrence, telling me I should not distinguish these two groups of patients. They need adjuvant CDK4/6. And then, of course, you've got your node-negative, non-high-risk patients that actually do very well. When we look at this data set that comes from meta-analysis of patients enrolled in more than 14 randomized clinical trials, more than 30,000 patients, stage 1 to stage 3 disease published since 2013, what you essentially see, let's go forward. What you essentially see is in those patients who are high risk stage 1, or high risk stage 1 or N1, the risk of recurrence, this node-negative high risk, has a similar recurrence to N1 at about 6 to 7%. And when you look at the node-negative in the control arm, that's the blue box, in the control arm of CDK4/6 inhibitor trials, the risk of recurrence is 10%, and in the N1 high genomic risk is also 10%, further reinforcing that those N1 high risk or those node-negative high risk are doing very similar to our N1 high-risk group of patients. When you go back to Natalie and you tease out those patients who've got node-negative disease, you can see about 300 patients in each arm of the study. You look at your stage 2A patients, about 70 patients enrolled. Half of them were grade 2 with a high risk or grade 3 disease. And you can see that majority of these node-negative patients were considered high risk by their physicians and actually received either neoadjuvant or adjuvant chemotherapy. But again, when you go back to Natalie, these patients do benefit from adjuvant ribociclib, 5.7% absolute benefit in terms of giving adjuvant ribociclib with endocrine therapy. Don't forget about long-term risk of recurrence. Why? Because we do have data from the early stage breast cancer trialist collaborative group that tells us that even if your patient has a small tumor versus a big tumor, node negative versus high tumor burden in the lymph nodes, or even those patients with low grade versus high grade disease, patients with ER positive, HER2 negative disease have a long-term risk of recurrence. And you can see that very clearly here on the Kaplan-Meier curves, that this is the reason why we give extended adjuvant endocrine therapy that goes up to 10 years. So let's look. If our patient is considered to be high risk, would they benefit with a CDK4/6 inhibition in terms of preventing long-term risk of recurrence? Simple answer is with monarch-E, we have 7 years of follow-up, and with Natalie, we have 5 years of follow-up. And what we essentially see is that with time, those Kaplan-Meier curves are continuing to separate, telling us that 2 years of adjuvant abemaciclib or 3 years of adjuvant ribociclib is having some form of carryover effect, protecting our patients long-term. Whether this will continue with time and there will be no coming together of the Kaplan-Meier curves is something that we will have to wait and watch as we get further follow-up of data. So this is my last slide in terms of the questions that we are going to ask, but in summary, abemaciclib plus endocrine therapy significantly improves IDFS in patients with hormone receptor positive, HER2 negative, node positive, high-risk early-stage breast cancer with an acceptable safety profile, and it now shows an overall survival advantage. Ribociclib plus endocrine therapy significantly improves IDFS in patients who are considered to be high risk as well as intermediate risk, including those node-negative patients with an acceptable safety profile, and we've seen a strong trend in terms of overall survival benefit, but still not statistically significant. Now, going forward, we'll have several questions that we're going to ask, which I could have addressed in my MDT earlier on or today, but in this lecture, but I was constrained with time. The question that we ask ourselves, what is the optimal duration of CDK4/6? Should it be 2 years? Should it be 3 years or more? Are we only delaying the emergence of early recurrences? What are the long-term side effects of CDK4/6 inhibition? And one of the questions that Matteo didn't answer during his lecture was, do CDK4/6 inhibitors impact ovarian function? Please address it next time, Matteo. How will we sequence in the presence of a BRCA mutation? Normally, with Olympia, with the overall survival advantage that we saw early on, we tend to give olaparib first, followed by CDK4/6. But is that what we should be doing is a question we don't have data for. Is there a role to de-escalate chemotherapy, both in the neoadjuvant and adjuvant setting? Really asking that question, one, is chemo necessary in those small tumors and node-negative disease? And two, is an anthracycline even important, something we don't have data for? And finally, how will we approach management in a patient whose disease recurs post-adjuvant CDK4/6? There's been some very interesting early data from the Dana-Farber group that's actually shown that when these patients relapse, and it's not very common that they will relapse, but when they relapse and you biopsy their tumors, nearly 30% of these patients are going to lose ER expression, transforming them into a triple-negative breast cancer. Again, highlighting the importance of not only biopsy, but how do you treat these patients? So I hope that you've enjoyed yourselves, and I'm happy to answer any questions. So thank you very much.
Thank you, Shahina. So we have 7 minutes for Q&A. Any questions from the floor? While we're waiting for questions, I want to ask you, actually, you brought this up earlier in the MDT, is when you have the clinical high-risk features, the grade 3, KI67, and then you also do the genomic scoring, if there's discrepancy. So high-risk clinical features, low genomic scoring, what is your take on this? Do you go with the clinical features?
So very good question. I would do, first of all, what Matteo likes to do and have a discussion with my patient about those risk features. But I tend to use the RS-Clin score quite a bit. I go online and I actually plug in the clinical features. So RS-Clin is really cool in that it not only takes the age of the patient, the size of the tumor. So when you go online, you actually put in the age of the patient, the size of the tumor, the oncotype score, plus it asks for the grade of the disease. So when you put those features in, it actually tells you what is the probability that this patient is going to recur in 10 years' time, but it also tells you what is the risk reduction with chemotherapy. And so when I see those discrepancies, I use RS-Clin quite a bit. And if RS-Clin is not available, I think it's your clinical acumen and that discussion in the MDT and with the patient that's so important. So if I have a patient, KI67 is 50%, 30-year-old lady, grade 3 disease, and oncotype has come back to me as 18 or 20, I'm going to have a discussion with her that she probably requires chemotherapy.
An audience asked about the optimum dose of ribo. I presume that one is quite clear.
So I think the trial was 400 milligrams. So I think it was very strategically put in terms of 400 instead of 600 because automatically less neutropenia, plus you're giving 3 years instead of 2 years. But still, we see those patients with neutropenia, especially after giving adjuvant chemotherapy in these patients. So I'm very happy to go down on the dose. So if you took either 200 and 400, it's fine, but you should always start with 400. And if the patient doesn't tolerate, then you go down the dose to 200.
Yeah. So I think with the maturing data, not many people will argue the benefit of adjuvant CDK4/6 inhibitor in this high-risk group. So, so a very high-risk group. I know it is Novartis Symposium. What is your take on this?
So what I learned in the previous MDT discussion is it's good to be diplomatic. But in that ultra high-risk group of patients, quite honestly, I think it boils down to the risk profile that you have in terms of the side effects. And if I have a patient that is, say, 90 years old, I'm going to say 90 or 80 years old, and I really don't want the headache of diarrhea and things like that, I'm probably more inclined for ribociclib. But if I have that patient that's decided to be the one that will go and take every alternative therapy that may potentially interact with the medication, I probably would do abemaciclib because of that QTC prolongation. But I really think it boils down to, one, my mood of the day, whether I want to prescribe ribo or abema, two, the patient that's sitting in front of me, and of course, the side effect profile. So.
Yeah. So another case that was brought up in MDT earlier, these very young patients, they cannot tolerate the AI very well. So you have to switch them to tamoxifen. So would you just do what we discussed earlier, tamoxifen and ribo, and what do you do?
I think we have to have a very, very clear-cut discussion with the patient that the combination of tamoxifen and ribociclib does enhance the QTC prolongation. And that can be a risk, and it's a very significant risk. It may not be a big risk, but it is significant and something that we have to have the discussion with the patient. I wouldn't routinely do it. I would encourage my patient to go back on the aromatase inhibitor if they're already on ribociclib. And remember, we have 3 aromatase inhibitors. And what I've found is if they're not able to tolerate one, sometimes you just give them a break, especially since they've come back from chemotherapy and you've done ovarian function suppression, and it's a young woman. Sometimes you just need to give them a break. When you give them a break and then you restart them on, say, another AI and gradually take them on to getting the CDK4/6 inhibitor, you will find 9 times out of 10 they are able to tolerate that AI. So I would do that before I totally abandoned it.
I see. Okay, Tarantio?
Hi, just a question on a lady with a postmenopausal status with 1 or 2 at the most nodes and low oncotype DX score, and you're going to de-escalate chemotherapy. What's your approach to adjuvant CDK4/6 inhibitors in that?
So I always say that oncotype tells you the benefit of chemotherapy. It's not telling you the benefit from endocrine therapy. It's not telling you the benefit from a CDK4/6 inhibitor. So essentially, the oncotype is telling me this woman is going to have practically no benefit from chemotherapy, but she's still got node-positive disease, so her risk of recurrence is high. And so she deserves adjuvant endocrine therapy first, optimize that, and then add the CDK4/6 inhibition, which will not only benefit in terms of trying to overcome primary endocrine resistance, but of course, long-term risk of recurrence.
So a question on Slido is weak positive ER, so very heavily lymph node involved. Would you offer CDK4/6 inhibitor as well? The weak ER positive, let's say 1%.
1% I would not offer because that patient should have received immunotherapy plus chemotherapy in the Keynote 522 type of protocol with 1%. My cutoff is less than 10% for trying to give the Keynote 522 protocol.
After Keynote 522, let's say 10% of ER positive.
So I think those patients, you have to have a discussion with them. If you look at the trials, especially in the metastatic setting, and even if you look at Monarch E, it actually shows you that irrespective of the ER expression levels, abemaciclib actually works in these patients. So I would not deny a patient that's got 10% or even 5% in the adjuvant setting. I would not deny them a CDK4/6 inhibitor, but I certainly would not combine it with immunotherapy.
Yeah. Last question is lidERA. So how would you do in the future?
I think lidERA is an amazing study that's telling us that oral SERDs are benefiting our patients in the early stage setting. But one, I think we have caveats. One, we need more follow-up. Two, we don't know if it is better than giving a CDK4/6 inhibitor plus an AI And 3, we have to wait for other studies which are actually exploring the combination of oral SERD plus CDK4/6, because I think that's where we're headed in terms of improving prognostic outcome for our patients. So I think we need to wait for that data. It's very exciting. In the next couple of years, we're probably going to be back here talking about oral SERD plus CDK4/6. Cambria-2 is, I think, almost completed accrual, in which 30% of the patients were given Abema plus camizestrant. In lidERA, there was a subgroup that got CDK4/6 plus gardadestrant, but again, we don't have the data for that, so we really do need to wait before we start to implement it into clinical practice. I think there's a question.
Okay, last question.
Thank you. I'm Julie from Indonesia. I have 2 questions for you. Will you treat the patient same way if you got the pathologist report? The lymph nodes has already ruptured and lymphovascular invasions. That's my first question.
The lymph node has ruptured?
Yes.
And so there's disease in the lymph node, or it's just ruptured?
Just say it's 1 or 2 positive lymph nodes, but the lymphs are already ruptured.
Okay.
Okay. And the second question is, after 2 years of 2 years or 3 years of the CDK4/6 inhibitors, what examinations do you recommend to make sure the cancer is already, disappear? On the contrary, maybe for you it's no financial constraint, but many parts of the world we have financial constraint.
In terms of what you're going to do in management?
Yes, follow-up, for the follow-up.
Follow-up.
Thank you. Surveillance maybe.
Okay. So in terms of lymph node rupturing, it doesn't really matter. So long as it's positive, you give adjuvant CDK4/6. And I would probably, if there's no other high-risk feature, probably give ribociclib in this patient, because it doesn't sound like there's any other high-risk feature to warrant Abema. In terms of follow-up, I don't think it's a question of financial constraint or not. All these patients should be followed up the same, and that is just, examining them in your clinic, doing your routine blood tests. I would not advocate after 2 to 3 years of adjuvant CDK4/6, which is what I think you're asking, whether we should be doing any imaging. The only imaging we should be doing is breast imaging. We have no data to tell us that we should be doing like PET CTs or CT scans or ultrasounds. You only image when the patient is symptomatic or complaining of something. And I have to admit, the minute they have a little bit of a pain here and there, I have a very low threshold for imaging, but I would not do it without that symptom.
Thank you.
Okay, thanks to Dr. Shaina. Please fill in the post-event survey form. That's close the session. Thank you.